Okay, our next case is a patient who presents with chief complaint, my skin is breaking out. You have a history of a 17-year-old girl who comes to the office complaining that her skin is breaking out. She has no prior history of skin problems, but she has noticed that during the week before each menstrual cycle, she develops red pustules on her cheeks, on her chin, and on her back. Okay? So during a hormonal cycle, she's starting to get pimples. These changes improve over the course of the month, only to return prior to her subsequent menses. She has no other significant past medical history and has never taken any oral contraceptives. She's a thin woman and she's in no acute distress. All of her vital signs are normal and her physical exam is unremarkable except for numerous comedones around her cheeks and her chin and scattered erythematous pustules on her cheeks and her upper back. If we think about our differential diagnosis, we should be primarily thinking about acne vulgaris. However, in order to expand our differential, other things that would also be considered would be seborrhea, the malar rash, and rosacea. The first thing that you want to obtain, like always, is to get a careful history of factors that would influence the flares of changes in skin. You want to ask about diet, you want to ask about stress, you want to ask about menses. You also want to get a careful history of anything that the patient has tried, such as topical medicines. Other parts of the history that should be considered is, are we using cosmetics, any antibacterial soaps, or any lotions? I can tell you that if you're taking your exam, that the least thing that has been proven to cause acne or to cause pimples would be diet. So, although some of our adolescents will tell you, I break out if I eat potato chips, I break out if I eat chocolate, this would not be scientifically proven. Therefore, the change of diet would not really be a choice of therapy unless you just wanted to offer the adolescent a healthier lifestyle. Acne vulgaris is a skin disorder that's primarily involving the sebaceous glands and most commonly will involve the skin that's on the face, on the chest, and on the back. And you're going to have sebum from the gland surfaces that will adhere to the skin via the hair follicles. You can also see comedones with acne, and this is usually secondary to pilosebaceous ducts that are becoming impacted. And you could have whiteheads, which are usually referred to as closed lesions, or you could have blackheads that are usually referred to as open lesions. The patient who has acne usually ends up having inflammation. And at some times, this can lead to pustules and cystic changes. The cysts are often related to abscess formation. And a characteristic lesion of this would primarily involve the face. Although the age and stress and hormonal changes are all thought to be significant, diet has not been shown to be a significant factor. Puberty often worsens the acne because there's an increased sebum production by the sebaceous glands. And the bacteria called Propionibacterium acnes will release fatty acids and will start to cause some inflammation. Cosmetics, especially with females, can also clog the hair follicles. So if you had a person who presented with acne, what would be your treatment plan? Well, the first thing that you would want to do is advise the patient to keep the face clean with plain soap and water. You want to avoid any antibacterial soaps. The second thing that you'd want to make sure that you used was benzoyl peroxide, 5%. You also might, if it's resistant to benzoyl peroxide only, use clindamycin topically to the affected areas. The thing that you want to make sure that you remember as far as the treatment is that after the topical therapy, if that is resistant, then what you want to do is add oral antibiotics, such as erythromycin or tetracycline. If you still have a severe acne with cyst and abscess formation, you might suggest to the patient that they use oral isotretinoin. This, however, can be teratogenic to fetuses. Therefore, if you're giving it to females, they must have a pregnancy test prior to being placed on this, and they must agree to not becoming pregnant for a minimum of a year. The other therapy that we can do is surgical therapy. And this is just injection of low-dose, mid-potency glucocorticoids for the painful nodulous cystic lesions. The next thing that we want to consider in the differential diagnosis when we're thinking about a patient who has acne is, does this patient have seborrheic dermatitis? You might recall that seborrheic dermatitis is often seen in young infants, and it's sometimes referred to as cradle cap. What I want to remind you is that young adolescents who had seborrheic dermatitis as infants may develop seborrheic dermatitis again during their adolescent years. Seborrheic dermatitis will have the buzzwords of being greasy, erythematous, yellow, or salmon-colored. It can be located in areas of the body that have high concentrations of sebaceous glands. In the infant, the scalp or the diaper area would usually be involved. However, in the older child, the rash may appear on the face, on the trunk, and on the neck. Remember that inflamed lesions will respond to a topical corticosteroid therapy. The other differential that we had was the malar rash. And the malar rash will be significant to make the diagnosis of acute cutaneous lupus erythematosus. In this rash, you're going to have erythema that crosses the nose and the malar eminences. It's sometimes referred to as a butterfly rash. If you ever hear or see a butterfly rash, you need to be thinking to work this patient up for the diagnosis of lupus. Remember that lupus not only involves the skin with a butterfly rash, but other associations can be seen as far as systemic illness with the disease affecting the kidney, can affect the lungs, and the brain, and almost every organ system. As far as your goals of therapy for the malar rash, it would be photoprotection and control of the systemic disease of lupus. The last thing that we would want to consider in an adolescent who had facial lesions would be acne rosacea. This is not associated with comedones, and what you need to remember is that it's usually a diagnosis in older patients, so patients greater than 30. So it's more of a pure adult disease. It's also, though, found on the cheeks, the nose, the forehead, and the chin. You'll see small telangiectasias, erythema, papules, and pustules. The treatment would be topical metronidazole, oral tetracycline, and non-fluorinated topical glucocorticoids. This would conclude our case on acne vulgaris. Our next case will involve a case of a patient who comes in complaining of knee pain. You have an 11-year-old boy who recently began playing baseball in a local Little League. He noted that his left knee is painful after his first practice. He does not remember any trauma to the knee, but he did slide on to second base. His knee began hurting him that evening, and he treated it with elevation and ice. It improved slightly, but 2 days later he noted the onset of swelling and discoloration over the skin. He denies any fever or chills or any history of nose or gum bleeding. The vital signs are blood pressure 110/70, pulse of 70, and temperature of 98.6. On physical examination, we see that the patient has clear lungs, a regular heart rate, and no hepatosplenomegaly. His left knee, however, is swollen and discolored, and he is unable to bear weight. There are no petechiae noted. We need to think about our differential diagnosis, and we need to consider things that could result in knee pain with this scenario. The most obvious would be, did the patient have a traumatic injury or a ligamentous tear? The second would be, does the patient have an infectious arthritis? Another differential diagnosis might be, does the patient have hemarthrosis secondary to hemophilia? And finally, we should consider, does this patient have von Willebrand disease? So we need to make an initial diagnostic plan. And what we can do is first to get a complete blood count, especially if we're considering that the patient is having some type of bleeding into that knee space. We also want to make sure that we get a prothrombin time and a partial thromboplastin time. We're looking for fibrinogen. We want to make sure that we have a plain film of the knee and aspiration of the knee, since there's fluctuance, should be considered. If we look at the WBC count, we see that we have normal white count with normal hemoglobin and normal platelets. The PT time is 12 seconds. However, the prothrombin time is elevated at 75 seconds, with normal being less than 35. The patient also has on X-ray an osteoarthritis and articular fibrosis that is seen. It was concluded that your next step should be to do an arthrocentesis. And what we find is that the patient has clotted blood with a gram stain that's negative for organisms and a culture that's negative. As soon as you see that your PTT is prolonged, and with this history of trauma, you need to be thinking about, does this patient have hemophilia? If you really knew that the patient had hemophilia, you would not have stuck a needle in the joint. However, because this was a newly diagnosed case, and the patient did have an effusion, the arthrocentesis was done. Once you found clotted blood, a gram stain that was negative, and a culture that's negative, you pretty much have your diagnosis. This patient would present with trauma-induced delayed bleeding into the deep tissue. This is suggestive of coagulopathy as compared with an immediate mucosal bleeding seen with platelet dysfunction. This is further supported that there's no platelet dysfunction because you're not seeing any petechiae. Oftentimes, patients who have idiopathic thrombocytopenic purpura, who have a platelet dysfunction, once they have a trauma, they present with bruising. They present with the petechiae. In this case, you don't have that. This patient has an abnormal PTT, but a normal PT, suggesting that this problem would be exclusively affecting the intrinsic cascade, pretty much factors 8, 9, 11, and 12. If we consider factor 7 deficiency, this would not be associated with clinical bleeding, so we're able to rule this out. Factor 11 deficiency does not uniformly result in bleeding. If you have a young man, we must consider that the patient has mild hemophilia due to either factor VIII or factor IX deficiency. The presence of a factor inhibitor is also possible. So, what would be your initial diagnostic plan? Well, first of all, you'd want to take the blood and you'd want to do a mixing study. You'd also want to look at bleeding time because remember we said that von Willebrand's would have a prolonged bleeding time. However, in von Willebrand's, the PT and the PTT would be normal. And you want to get a factor VIII and a factor IX level. The thing that you want to do here is notice that in our results, by doing the mixing test, you corrected your deficit. Everything else was normal, and you had 5% normal level of factor VIII. So this patient does have hemophilia. What would be your treatment for a patient who is newly diagnosed as a hemophiliac? In this particular case, you would be thinking about infusion of factor VIII concentrate or cryoprecipitate to raise the factor VIII at least to 25% of normal. The other thing that you want to do is to eliminate further trauma to this particular joint, and so you might consider immobilizing it. You want to make sure that you get an orthopedic and a physical therapy follow-up. Your final diagnosis is going to be hemophilia VIII, and this particular patient would have a mild to moderate hemophilia, especially in the fact that he is 11 years old. Now, hemarthrosis secondary to hemophilia, you might see excessive bruising being visible secondary to trauma. You might also see bruising with ambulation resulting in a hemarthrosis. We've talked about the lab results and we've talked about the treatment. Remember that in mild hemophilics, if we use DDAVP, this will increase factor VIII. You want to always avoid aspirin in anybody who has hemophilia and any antiplatelet medications. What if this patient had had a traumatic injury or ligament tear? How could we have come to that conclusion? Well, first of all, you want to inspect to see if there was any hemarthrosis or any obvious deformity. Remember that the patient would have pain or laxity with an associated maneuver indicative of perhaps a ligamentous injury. If your patient was unable to bear weight, you would give the patient crutches. Always remember to give the patient crutch instruction. The reason being is the crutches are like a weapon, and you wouldn't give a person a bicycle helmet or a car seat without giving them instructions on how to utilize it. The same with crutches. If they have an accident, you'll be liable. The other thing that you want to make sure is in traumatic injury that you would obtain a plain film, and rehab would be indicated. What about infectious arthritis? Well, first of all, for an infectious arthritis, that would be an infection in the joint pain, in the joint space. We talked briefly about this morning when we talked about the septic hip or the septic knee. Remember that if you're a newborn, you're susceptible to having Staph aureus, group B strep, or gram-negative bacilli causing a septic arthritis or an infectious arthritis. And it's common to see infants that present with septic arthritis in the hip. Children younger than 5 will have infections secondary to Staph aureus, streptococci, and Haemophilus influenza. And usually the Haemophilus influenza would be in children who aren't immunized. Remember that in order to assess the infectious arthritis, one of the things that you're going to do is to move the joint through a full range of motion. If the patient refuses to bear weight on the extremity, or has a decreased or refuses to permit you to do that full range of motion, you must think that this patient has a joint infection. The other things that might help you are pain, tenderness, warmth, and swelling at the site. Always, to make your diagnosis of a septic knee or an infectious arthritis, you have to do the arthrocentesis. And once you do the arthrocentesis, you're going to look at the cell count and you're going to send it for a gram stain and also for culture. This will help you to identify the organism that's causing the joint infection, and you can treat with the appropriate antibiotic. Von Willebrand disease was also on our list for differential diagnosis for this particular patient. We've talked a little bit about von Willebrand's disease throughout this lecture, but what we need to remember is that we have prolonged bleeding time because the platelets in patients who have von Willebrand disease have a decreased adhesiveness. Clinically, you're going to see the patient oozing or having prolonged bleeding. There may be a history in the family to help you make the diagnosis. And as we said earlier, the treatment for von Willebrand disease will be fresh frozen plasma or cryoprecipitate and DDAVP. The next case that I'd like to present is the chief complaint of cough and shortness of breath. In our history, we have a 5-year-old child who's brought to the emergency room because of a cough and shortness of breath. He has progressed the cough and shortness of breath over the last 5 days. About 3 days ago, he was noted to have upper respiratory symptoms with a low-grade temperature and rhinorrhea. He developed a non-productive cough with increased respiratory rate and poor exercise tolerance. This is the first time that the child has experienced these symptoms. He appears alert and cooperative. His vital signs are that he's afebrile, his respiration and pulse are within normal limits, as are his blood pressure. Physical examination is pertinent only for watery nasal discharge, non-tender sinuses. His throat is pink. There are no lesions or exudate. He has a supple neck. There is mild accessory muscle use. This should be noted. He also has in his lungs diffuse and expiratory wheezes without crackles or egophony. His heart sounds are normal without a murmur. His abdomen is within normal limits, as are his extremities. His nail beds are pink. We need to be thinking about our differential diagnosis for this particular patient. The fact that this patient is short of breath, that the patient has problems with exercise, and that the patient has a persistent cough, as well as normal color in his nail beds, and no clubbing noted. Most likely our working diagnosis for this particular patient who's using subcostal muscles would be asthma. However, other airway problems that we need to be thinking about would be croup, epiglottitis, foreign body aspiration, allergic reaction, bronchiolitis, and pneumonia. The first thing that you want to do in this particular patient who comes in with respiratory distress is to make sure that you obtain a pulse oximetry. You obtain the pulse oximetry and you find that the result is 91% on room air. This is not good. The pulse oximetry should be with an oxygen saturation greater than 95%. You also have tried to do a peak expiratory flow measurement on this child who you suspect has asthma. And he does 70% of what would be predicted for his height and for his age. This is also putting him into a cautionary zone, telling us that he does indeed have respiratory distress and needs intervention by you. The one thing that I'd like to discuss is that in this case, this is really typical of asthma. You need to be thinking about what triggered the patient's problem. Did the patient have a viral upper respiratory infection? Was it a weather change? Was it exposure to an animal? And so you want to really make sure that you understand what was the trigger. In your history, it would be also important to find out how severe is this asthma? Has it ever occurred before? Was this patient ever admitted to the hospital for similar symptoms? And was the patient ever intubated? Because what you do as far as disposition with the patient will depend on their historical data as well as their response to therapy. If the patient is known to be a severe asthmatic who has many times gone to the intensive care unit or even one time has gone to the intensive care unit and or has been intubated, you would have a very low threshold to admit that patient to the hospital for observation, whether or not you were able to control the asthma in your office or emergency center. Other things that you need to be thinking about with relation to our differential diagnosis is that in this particular case, epiglottis is most likely ruled out because the patient is not complaining of sore throat, the patient is not drooling, and the patient does not appear to be toxic. And the patient is also afebrile. You know that with epiglottitis, that the patient usually has a sudden onset of sore throat, looking toxic, with high fever. The history and findings do not also suggest croup. Why? Because the buzzword for croup would be that the patient had barking cough. And on occasion, they would say that the patient had stridor, which would be similar to this sound. So we have no evidence of that. The patient likewise would have foreign body as being low in our differential diagnosis because with foreign body we would have localized wheezing with decreased breath sounds. In this particular patient, the patient has end expiratory wheezing scattered throughout. However, whenever a patient presents in respiratory distress, it's important for you to have a differential diagnosis in your mind so that you can rule in or rule out a particular diagnosis and help to manage your patient efficiently and expeditiously. Likewise, there's no history of allergic or toxic exposure. You note that your patient is tachypnic. The patient has retractions. So the patient is working to breathe. The flows are really in a moderately reduced range, so it would not be safe to send this patient home unless he could demonstrate improvement. And his oxygen sat is really borderline. We want to keep it above 95%. This patient may require inpatient therapy if he does not respond to your treatment plan. So what would your treatment plan be? Anytime a patient has a respiratory distress, we need to be thinking about giving oxygen. And you could be giving this patient oxygen either by nasal cannula or non-rebreather. In addition, you want to make sure that you give an albuterol nebulizer, all right, a bronchodilator. If the patient has had a history of having these asthma attacks in the past, then, and if the patient has been on albuterol, then what you want to do is make sure that you, in addition, add oral prednisone. Remember that some of our patients have nebulizer machines at home, and the parents have already tried that. So to come to the hospital for care and to receive nebulizer after nebulized albuterol treatments without the addition of steroid would probably not be beneficial. The further diagnostic plan in this particular case included a chest x-ray. And the chest x-ray shows diffuse hyperinflation without infiltrate or fusion. Now I want to make a comment about your need and your use of chest x-ray in patients who have asthma. First of all, if you have a patient and you know that they have asthma, the diagnosis has already been established, it is not necessary to order a chest x-ray every time the patient presents to the emergency center. it's not cost effective, and it's not in the best interest of the patient to expose the patient to this radiation. However, there are some circumstances where a chest X-ray would be beneficial. One of those circumstances would be if the patient had fever and presented with what appeared to be an asthma attack or respiratory distress. The reason that this would be beneficial again goes back to the statement that all that wheezes is not asthma, even if you have asthma. For instance, if the patient had fever, the patient could have pneumonia, or even though our breath sounds and wheezing were scattered throughout, you might have a foreign body aspiration. So those would be your times when your chest X-ray would be needed. In your management, unless you had those kind of scenarios, or if the patient's condition was worsening rather than improving, and you suspected that perhaps the patient had a pneumothorax, you would not get a chest X-ray. What would be your further plan? You've given him albuterol, you've given him steroid. Even if the patient responds, you are not able to just send the patient home. All right? You need to observe the patient in the emergency center or in your office for the next few hours. The reason that you're observing is to make sure that the patient does not have any rebound. If the peak expiratory flow and the oxygen saturations improve, if the respiratory rate slows, he could be considered for discharge for outpatient therapy. However, when you send the patient home, you want to have explicit directions that this patient should be taking his albuterol on a regular timed basis. And in addition, the patient should be given 4 days of oral steroid. Now, many of you who are internists might say to me, will oral steroid be beneficial, especially in this acute case? You said that you were using oral prednisone. Why aren't you using IV? There was a doctor named Rich Scarfone from Children's Hospital in Pittsburgh who, during his fellowship around 1990, looked at this to compare the effectiveness of oral prednisone versus IV prednisone use in asthmatic children who present acutely. And what he proved, and actually won an award for, was to show that in children, the oral prednisone is as efficacious as the IV prednisone. Now, are there any exceptions to the rule? Oral prednisone is very bitter, especially if you're taking it in a liquid form. Therefore, if you give the oral prednisone and the patient will not cooperate to take it, or if the patient vomits, then you would have to start an IV. However, if you think of the beauty or the benefit of giving oral prednisone, how many of you have ever tried to start an IV on a sick child who may be a little dehydrated, who may be pudgy, who may be dark-skinned, who you don't see any veins on? Giving the child multiple sticks, upsetting the child more, getting more asthma exacerbation, and also inflicting pain. So the fact that we could give oral prednisone and that it's as efficacious as the IV is a help. However, when the patient goes home, if the oral prednisone had helped in the emergency center, which it did if we were trying to intervene so that we could get the point of outpatient therapy, then you must send the patient home with oral prednisone. You're going to give it 4 days. Now, some of you may have a question and say, well, should I taper the dose? Do I have to give it? Why are you saying 4 days? Shouldn't we give prednisone over 10 days and taper the dose? The answer is that in children, we can give an initial 2 milligrams per kilo dose up to a max of 60 at presentation of the hospital. For the next 4 days, what we give is a 1 milligram per kilo dose, 1 time a day, without taper, up to a maximum dose of 60. So those things would need to be considered if the patient was going to go home. However, if the patient doesn't improve after a few hours of therapy, or if for some reason you have a poor social situation, or if you have a patient who has historical markers of being in the PDICU or being intubated in the past, these patients should be admitted to the hospital for further management and observation. Our final diagnosis, as we said, was asthma. Remember that this is a reversible obstructive airway disease. It affects both small and large airways. You will never see, or you should not see, clubbing if the primary diagnosis is asthma. If the patient had other diseases such as heart disease and asthma, or if the patient had cystic fibrosis and asthma, you may see clubbing. But typically they're going to try to give you the cleanest case that they can without giving you an obvious answer. And so if your patient does not have clubbing and you're suspecting that they have a respiratory problem, most likely it's going to be asthma. And the reason they don't have clubbing is because the disease is reversible. Remember that there's always three components that you should be considering when you're planning for your treatment or your management of the patient, and that would be bronchospasm, airway edema, and mucus production. So you want to try to target your therapy to target these specific entities. The etiology for asthma is still unknown, but it's thought to be genetic, and environmental factors play a role. Remember that the presentation can vary from mild to severe, and that usually there's a history of a cough. There may be a history of night cough. Whenever you hear night cough, there are two things I want you to think about. Does this patient have asthma, or does this patient have sinusitis? And by looking at the scenario, you should be able to differentiate and make a decision on your exam or for your patient for what your next step is. As far as treatment for asthma, we want to make sure that we give good educational instruction to the parent, that they avoid their asthma triggers for which each one is susceptible. Remember that patients with asthma may be classified as mild intermittent, mild persistent, moderate persistent, or severe persistent. And that the asthma classification is going to help you to determine what type of medication you need to give the patient to see if you could benefit the patient's treatment. Know that if you have a patient who has mild intermittent asthma, that this means that the symptoms occur less than twice each week, and that night symptoms would occur less than twice each month. Also remember that for the mild persistent, that the symptoms occur more than 2 times a week, but less than 1 time per day, and that you would have night symptoms that occur 2 times each month. Your moderate persistent is more severe, it's persistent, so you would see that the patient is having frequent coughing and wheezing symptoms. Your exacerbations, again, would be more severe. And the severe persistent are patients that have daily symptoms with severe exacerbations that oftentimes require hospitalizations. Now, if you have a patient who has the mild intermittent asthma, what you want to be thinking about is, since it's mild and it's intermittent, that you don't have to have this patient on daily therapy. All right? Usually, the patient is exposed to a trigger, perhaps change in weather, or he knows that when he gets a cold, he's going to start getting an asthma attack or wheezing. And so in that particular case, the patient would just take the medicine at the time of the symptomatology. However, if the mild asthma is persistent, then it would probably be best to have the patient take an anti-inflammatory such as cromolyn or an inhaled corticosteroid. When the patient would run into trouble, it would be at that time that the patient would take their beta agonist. For the moderate persistent, the treatment is inhaled corticosteroid, and it's going to be medium to high dose, plus a long-acting inhaled beta agonist. What you want to do is make sure that when the patient is symptomatic, that you're going to use a short-acting inhaled beta agonist. Remember that cromolyn and these inhaled steroids are not useful in an acute attack. And again, for severe persistent, your daily medications are going to include your inhaled steroids, which are high dose, plus long-acting inhaled beta-2 agonist. And again, when symptomatic, you're going to add the short beta-2 agonist. Now, there's an exception to the rule for children who have exercise-induced asthma that is different than the adult, and I'd like you to take note of it or make note of it. If you have a child who has exercise-induced asthma, it's best prevented by using a beta-2 agonist immediately prior to exercise and after exercise. All right? And this would be different than in the grown-up, where you might consider using cromolyn. Now think about the child. Why would this be recommended by Nelson? Well, if we're a grown-up, we may have a daily routine of participating in exercise. However, for a small child, they might be participating in Little League, midget football. By the time the cromolyn would take effect, the season would be over. You would not, we always want to give the patient the best lifestyle that they can have, the least invasive procedures, the least amount of medication, and we would not make this child be submitted to receiving cromolyn all year long if really the exercise-induced asthma only occurs during Little League in the summer months. So the beta-2 agonist would be the rule of thumb here for the patient who has asthma. The next thing that I'd like to just talk to you about for respiratory distress is croup. And although we wouldn't expect an older child to have croup unless they had a component of like laryngitis, we do need to know a little bit about croup. The one thing that you want to know is that it is caused by parainfluenza virus, and that's your most common cause, but other viruses can cause it. It usually occurs in children that are between 3 months and 5 years of age. They have the barking cough, the inspiratory stridor, and if you have stridor at rest, that's ominous. That's bad. And so you must intervene. You must do something. Okay? One of the things that you might see as a buzzword in your question, if it refers to croup, is that on X-ray of the neck that you see a steeple sign. And when we talk about steeple sign, or we could call it pencil sign, what we're talking is that there's a narrowing of the airway that's coming to a point. This is causing obstruction and giving you the sound of stridor. And this is a narrow subglottic space. Remember that if you have a mild disease, just like with bronchiolitis, you could give humidification, either hot or cold. However, we said that stridor at rest is serious and it needs to be treated or intervened. Therefore, you should know that your next step on the exam would be that the patient should receive racemic epinephrine. Now, I can tell you that approximately 10 years ago, as soon as the patient received racemic epinephrine, we immediately admitted the patient to the hospital. Why? Because there was a chance that this patient could have rebound. So the patient could get better and then could rebound and be worse. However, What was done in the early 1990s was a study that showed that if I give racemic epinephrine to these patients who have respiratory distress, and I add dexamethasone, IM, that I could observe the patient for approximately 4 hours. If the patient had no rebound, I could feel comfortable to discharge that patient to their home. However, if the patient worsened, if they developed stridor at rest, then what I would have to do is give another racemic epi, but I would have to admit that patient to the hospital. So this is something that they test you on, because they're going to ask you where to send the patient. If the patient's mild, you're treating with nebulized treatments, you send the patient home. Stridor at rest, you try to intervene in the hospital. You want to make sure you give the racemic epinephrine and, in addition, dexamethasone IM. Now, dexamethasone is long-acting, so it should last for about 56 hours. That's why you can feel comfortable to send the patient home after observation for 4 hours, because you're still going to have steroid on board that will continuously decrease the inflammation that is in the subglottic area. What else do you need to be knowing about? Epiglottitis. We said that epiglottitis was inflammation of the epiglottis, and that it too can cause airway obstruction. But what you need to know is that the patient will be drooling and will be toxic. It usually occurs in kids that are 2 to 7 years of age, and even though we have the vaccine and we don't see epiglottitis much in the younger children who are vaccinated, H. influenza type B is still thought to be the organism that causes this. Now, I can tell you that at our hospital, and the trend across the states, is that the patient will sometimes be older. Sometimes the patient will be an adult. We've seen at least 6 at our hospital, but they didn't have Haemophilus influenza. There's a new organism that's breaking through, and it's group A beta hemolytic strep. So you need to be aware of that, because epiglottitis can occur from birth to death. Remember that the patients with epiglottitis can be sitting in the tripod position, that if you did a lateral x-ray of their neck, that you would see a thumbprint sign. Remember, do not insert a tongue blade into somebody that you see that's drooling, sitting in the tripod position, because they may have epiglottitis, and if you put the tongue blade in, you may cause a laryngospasm. Remember that you are the advocate for your patient, and unless you're an anesthesiologist or an ENT specialist, you are not the most expert in the airway, even if you do emergency medicine. You must advocate, coordinate, call ENT or call anesthesia, and they should take the patient to the OR to look under general anesthesia to see if there's epiglottitis, and to also intubate the patient. It's only at that time that you would get blood culture, that you would start an IV, and that you would get your blood work, in addition to getting a culture of the epiglottis. Remember that you want to treat with IV antibiotics. A third-generation cephalosporin would be a good choice, and you want to make sure to decrease the inflammation by giving steroids like Decadron. Thinking about foreign body aspiration, remember that hot dogs, peanuts, coins, nuts, balloons, batteries, all these things can be aspirated by children. They can cause respiratory distress, and that the patient most likely will have a death due to a hot dog aspiration. So the leading cause of death from foreign body is the hot dog, and the most common cause of aspiration is the peanut. Remember that respiration or respiratory distress from a foreign body aspiration may not be so obvious initially, and that the patient may continually present with wheezing that's unilateral. Remember also that children younger than 4 years of age are at risk. If you needed a treatment or a diagnostic study as the next step in your management, it's always to do a right main stem bronchus inspection, okay? The other thing that you want to make sure is that if you did an x-ray, that you would realize that you would have the ball valve effect in those who could take a deep inspiration. If I take a deep inspiration and I have a foreign body, when I expire, my lung that's obstructed is still going to remain the same size. So you're not going to have a collapse and fill. If it's a small child, it's hard to do this particular x-ray. Therefore, you would have to put the child either in a left lateral decubitus to see if the dependent lung would fall, and then follow that with a right lateral decubitus. Again, the definitive diagnosis for foreign body aspiration would be visualization with a rigid bronchoscope. If we continue on our differential diagnosis, looking at allergic reaction, remember that this is an IgE-mediated response, and you can have allergies to any environmental products or drugs or food. Sometimes they'll have a pruritic rash. It may be in wheal form. It may be considered to be urticaria. And the patient may even have systemic problems such as respiratory distress, stridor, edema, vomiting, GI. And basically, what you want to make sure that you do is assess the situation. If this urticaria is severe, give epinephrine 1 to 1,000 sub-Q. Supplemental oxygen, or if it's not severe, give diphenhydramine. We've already discussed bronchiolitis and the pneumonia, so I'll stop here and thank you for your attention and wish you good luck on your USMLE Step 3.